Good evening, everyone. Welcome back to blackdoctor.org. And you recognize my guest today, Dr. Ryland Gore. She's been on before. And today, in case you didn't know what she does, she is a breast cancer surgeon, well, breast surgeon. So we are going to talk about breast cancer surgery today. There's a recent article on our blog, and we're just going to discuss the different options. Thank you for joining us.
Absolutely. As always, thank you for having me.
Of course, of course. So tell us exactly, from the lumpectomy to the mastectomy and why maybe you do what and, which one. And
Yeah. One thing in the article that really stood out to me was lumpectomy versus segmental mastectomy versus we don't do lumpectomy is lumpectomy is lumpectomy. And so it can be a partial mastectomy. That's the old school way of saying it. Quadrantectomy, you're removing a quadrant or a portion of the breast. That's another old school term for it. The point is all of it is breast conservation. So we don't really make a distinction and say, oh, a segmental or partial mastectomy is larger than a lumpectomy. At the end of the day, the goal is to remove the cancer, remove some healthy tissue along with the cancer so that you have negative margins and try to maintain the shape of the breast. Because one thing that's so important that surgeons actually think about now 2024, I was about to say in 2023, is not only did we remove the cancer, but did we leave the patient something that they will be happy with? And so when we talk about should somebody get a lumpectomy versus a mastectomy or whatever, generally, if somebody is a stage 1 or stage 2 and that tumor is still small, especially in relation to the breast size, they will be a lumpectomy candidate. But another thing we think about is even if somebody has a small tumor, say it is 1 centimeter, but you have negative A cups, you might not be a good breast conservation candidate, even though you're technically early stage, right? And so one thing I love about how breast surgery has changed over the years is that we're looking at form and function, and the woman should still feel happy with what she's walking out with, because the difference between this versus other cancers, for example, is that the breast is an outward structure. And so, yeah.
yeah, it's everybody can see.
Everybody can see it, including that woman that has to look at this every single, look at
Exactly.
herself every
In the
single
mirror
day.
every day. Yep, exactly. So my question is, do you so you recommend what type of surgery?
It depends. There are some patients who want to do everything to save their breast, right? And it's like, ma'am, you have cancer all over this breast. We cannot save the breast and save you. And so
Right.
there are some situations where a patient is not a breast conservation candidate. And I will absolutely say, I'm not offering you breast conservation because you're not a candidate. And they can only be offered mastectomy. But I do think it's important that every single woman is offered the option for breast reconstruction and consultation with the plastic surgeon. And so that's the caveat, because we do
That's what
have
I was
surgeons.
gonna say. So so if you do have a mastectomy, then everyone could get uh, some sort of breast reconstruction.
We try to offer it, and we try to make it an option as much as possible for patients. I will say that we all know plastic surgeons are very picky about who gets what. I will say that a lot of the plastic surgeons I work with, they kind of stretch the parameters to accommodate breast cancer patients because, you know, reconstruction for breast cancer is not considered cosmetic, and so in that same vein, insurance pays for it. It's not
Right.
cosmetic, it's a reconstruction. And so it is in general offered, but as we know, most cancer patients are more likely to be older, they're more likely to have a ton of health issues, they're likely to be sicker. And so you do have cases where regardless, they're not going to be a reconstruction candidate because of all the other things going on. But I make it so that the plastic surgeon is the one to have that discussion with the patient. I think it's important that breast cancer patients feel like that was thought about and that it was offered and that there was a discussion surrounding that, whether they're a candidate or not.
So and also, do you also base your decision on if they have the markers, maybe?
Oh, the tumor markers?
Yeah.
No, that's not a consideration in breast reconstruction at
No, no,
all.
not reconstruction. I'm saying surgery.
Oh,
So
absolutely.
lumpectomy versus mastectomy. Okay.
So Not necessarily. For me, it's still going to be size. And so the markers will give me an indication of, is this tumor a good guy or is this really a bad guy? Is this an aggressive cancer? And it lets me know, does the patient need chemo first? Between the markers and the size of the tumor, how extensive the disease is, does the patient need chemo first or not? And sometimes even if a tumor is, say it's less than 5 centimeters, but it's borderline in size in relation to the patient's breast size, I'll have them get chemotherapy first so that it can broaden their surgical options. Because there are some patients without chemo and without the tumor being shrunk, you can't save the breast. And there are some patients who are willing to do everything to save the breast. And so it's just such a very nuanced discussion. People think breast surgery is just so easy,
Right.
but like, cancer care is not easy. There's so much that goes into it.
And then what about the genetics testing now that we have? And, maybe every woman in my family's had breast cancer, and then I come in and I want a lumpectomy.
Great question. So number one, I recommend genetic testing, and it is a recommendation from the American Society of Breast Surgeons that every single patient with a breast cancer diagnosis gets genetic testing. But it's also important, because that may make a difference between whether a patient chooses breast conservation versus saying, you know what, I'm high risk. There's BRCA in my family, or there's XY gene in my family. Let me go ahead and do prophylactic mastectomies so that I can reduce the risk of this happening again. And also, when it comes to certain drugs that we give patients who have genetic mutations, for example, PARP inhibitors for patients who are BRCA1 positive, things that we know that will help reduce their risk of recurrence in the future. But we won't know that if the patient is not offered genetic testing and it's not actually done. And so I strongly recommend genetic testing for patients, because not only does it impact what treatments may be offered, but it also will impact what their surgical decision may potentially be.
Okay. And then, so you said there's different types of mastectomy, partial or full. Then the after you, so you have some people that have chemo before and some that have after, correct?
Correct.
Okay. And also, when is a reason that you would have to remove the lymph nodes?
So I just want to, the article was kind of weird on this. And so in general, if a patient has invasive disease, in the overwhelming majority of breast cancer patients, it is invasive disease, you will be offered a lymph node biopsy. Now, the difference is, do the lymph nodes appear normal on imaging before surgery, or does the imaging appear abnormal? And so if a patient is clinically node negative, meaning I don't feel anything on examination, and their imaging is clean, then they get a sentinel lymph node biopsy, and usually between 1 to 3 lymph nodes are removed. That's small, that's nothing. For patients that have very suspicious disease, or it looks like their lymph nodes may be positive based on the imaging, or they have a biopsy that proves that the lymph node is positive, then they will get a full lymph node dissection. So there's a difference. And there's no distinction made between those in the article. And so sentinel lymph node biopsy, that's what most patients get. And then for patients that we know have positive disease, full lymph node dissection, where usually greater than 10 lymph nodes are removed.
Okay, and so that's when and that is because I have a relative that she her extremities on that one side are really swollen.
Lymphedema,
yeah,
very common. Not so much with sentinel lymph node biopsy, even though in rare cases it can happen, but with a patient that's had a lymph node dissection, the risk of developing lymphedema is up to 30-35% of patients with a lymph node dissection will get lymphedema.
Now, is there any way to get that down?
There are some centers that do, lymphovascular reconstructions. It's painstaking. It's painstaking. Y'all don't come to me looking for that, because I'm not doing it. Get somebody else to do it. But it takes hours. I mean, hours and hours. It's painstaking. But does it work? Yeah, sometimes it does. I think the biggest thing, you just try to prevent it, to be completely honest. And
Okay.
so I'm a very big proponent of not just rehab, but prehab. And so patients that I know will need certain things who are high risk for developing lymphedema, I have them see physical therapy before they even go to surgery so they know what to expect and they start learning exercises. They start getting fitted for the garments they need. I'm a big fan of early use of physical therapy, early use of compression garments, whether it's the gloves, sleeves, bras, everything that you can possibly do, lymphatic massages. Um, all the preventative things. No vaccines on that side, obviously, no shots, no blood pressure. Now, a common thing that comes up, which grates my nerves, a patient will get a lymph node biopsy, and then, the nurses are running around the hospital with red flags and saying the patient can never get anything done on that arm again. If a patient's had a lymph node biopsy where only 1, 2, 3 lymph nodes are removed, it is still safe to use that arm on that side if you need to. And so that's just one of those things that it's like painstaking to dispel, because once something just gets out, like
Right.
they stick to it. But for my lymph node dissection patients, absolutely protect that arm at all costs and use the opposite.
Gotcha. I'm trying to think what else, what other things would people think about?
Radiation comes up a lot. And I know
Okay.
the article brought this up. And some people will say, I'm going to get a mastectomy because if I get a mastectomy, everything is gone. I'll never get cancer again. Well, first of all, that's not true. So that's one myth I want to dispel. Have you drastically reduced your risk of breast cancer recurring if you get a mastectomy? Absolutely. But that risk never falls to 0.000. And I would say that the lifetime risk, depending on the patient and their own factors, anywhere from 1 to 5, 6%
Okay.
versus the average woman whose lifetime risk is almost 13% or whatever, and even higher if you have a genetic mutation. But lumpectomy with radiation and mastectomy, those two things are equivalent. And so the patients, stage for stage, are going to do just as well, whether they choose one or the other. And so I think that's an important distinction to make. And I think what people think about is, for all comers versus breaking it down by race. Yes, our Black women's 5-year survival is lower stage for stage than all comers. But in general, you picking a mastectomy isn't going to make it so that this never happens again. You're equal to the woman that chose a lumpectomy with radiation. And some people will say, well, I'm getting a lumpectomy, but if you send me for radiation, I'm not going to do it. Okay, do you? But the recommendation is the recommendation, and radiation does decrease the risk of recurrence by 50%. So these are things that patients should be mindful of when they're just kind of going through the process and trying to figure out what will and won't work for them. And I do have patients, as the article stated, that will choose mastectomy because they know they don't want to go through radiation. And so all of it, honestly, every single step of breast cancer treatment, it's a very personal decision, and people choose different things for so many different reasons.
Um, and I forgot to remind everyone the reason that they check that's why when we do a breast exam, you're supposed to reach under your armpit because that's where your lymph nodes are located, and so that's why it's so important to check those as well.
Yeah.
And then of course remind everyone that you should check your breast once a month.
Yes.
Same time every month.
Yes, that's preferred, but yes.
Yeah. And I think don't they say a week after your cycle?
I tell patients to do it usually a week after their cycle, just because the breast tissue is so tender and just so lumpy, bumpy pre-menstrual cycle that sometimes it's like, I don't even know what I'm feeling. After your menstrual cycle, the breast tissue is calmed down. It's not inflamed. It's not irritated anymore or as much. And so it's easier.
Yeah. And also if you do it every month, you'll know your breast. So then you'll notice if something is different or abnormal.
Absolutely.
A lot of people like to rely on the OBGYN or the whoever your family medicine, whoever your doctor is that does your annual, but that person has felt how many breasts all day long or all year long. And yes, they make notes and everything, but at the same time, you should know what
you should know your body. Yes.
Yeah, You need to look at them and
Please,
notice anything changing.
please, I implore you. It's amazing the number of people where I'm like, you see them and you're like, you didn't see this, you didn't feel this. And some people, they really don't pay attention. I think some of it is like the not wanting to know also, because when you know, you have to address something, right?
Right.
But just look at those things. And not everybody's breasts are symmetrical. Most breasts, unless you've
Not.
already had some work done, are not perfectly symmetrical. But being able to pick up differences. Did one breast get really, really large or really, really small compared to the other? That's a red flag. Any skin changes, new rashes, new nipple changes, nipple rashes, nipple discharge, skin dimpling, any kind of pulling. Um, and of course, a lump is a red flag, but just look out for the signs, y'all.
And you can't, the one thing about breast cancer is you usually don't feel sick. So that is why it's so important for you to please. And I mean, not just for your breast, you should
Yeah.
really stand in front of the mirror and look at your entire body and know yourself head to toe. So
Yes.
if anything shows up that isn't supposed to be there, you'll be the first to know. And you can call somebody and say, I need you to look at this. But it is amazing how many people are like, I had no idea.
And it's not like, like you said, Dr. Renee, it's not like, a GI cancer or some of the other cancers where there are noticeable things like weight loss. For so many cancers, weight loss is usually the first.
Right.
That's
or
not
blood and stool, colon cancer.
No appetite, things like that, or difficulty swallowing or whatever. You're not going to get, the breast is an outward structure. You're not going to get any of that. If you get a lump and you decide to neglect it, will you eventually have wound care issues and things like, yeah, but that usually takes time. And so really just paying attention to your body is super important.
Yeah. And I mean, I know me personally, I have cystic breasts, as they say. So they are lumpy and bumpy, but I know my lumps and bumps. So therefore, when there was a new one, I was like, wait a minute. So, I was like,
pause.
Not,
right. One of the native cysts, like this is the new one.
Exactly. So, this is why it's really important for you to
Right.
know. And, and then I learned in my mammogram after I lost 60 pounds, I'm just in the mammogram minding my business. The lady goes, "Ma'am, did you lose a lot of weight or something?" And I was like, "Yeah." She goes, "You need to let us know that because things are changed over here, and it doesn't look the same." And I was like, "Oh, I'm sorry."
That's a good point.
Didn't know that.
Your breast exam and your mammogram will change with large weight loss or weight gain, and so that's something to be mindful of. Also, for the ladies that have surgery, I'm a big fan of, people doing what makes them happy. So if you get plastic surgery, you get plastic surgery. But number one, if you get implants, you still need to get mammograms. And we can do mammograms safely in women who have implants. So that's number one. Number two, for the women who get breast reductions or any kind of procedure on their breast, it changes what the breast tissue looks like. And so a lot of times, especially if you get a reduction after a certain age, your plastic surgeon is going to want you to have a mammogram because they want to make sure there isn't anything going on. They don't want surprises either. And there's actually a cancer in there that when they're trying to reduce the tissue. But after, you'll probably need a repeat one anyway, because now the breast tissue looks different because you've had surgery on it. So just things to be mindful of.
Yeah, that's definitely a good idea. But the other thing I think is that there's so many I've heard about so many people who are pregnant and then they find out they have breast cancer. So do you still check your breasts every month still, while during pregnancy too?
You should check them.
It's just very, yeah, but
especially because now when you're pregnant, you're cooking a baby. The hormone levels are at an all-time high, and so most of the women who I've taken care of who have pregnancy-associated breast cancers, they're usually estrogen and progesterone positive. There are a handful that are triple negative because those are just aggressive tumors anyway, but absolutely, still check your breast. Okay. And if you do feel a lump, and especially if it's suspicious, you can safely get breast imaging while you're pregnant without it impacting the fetus. And so.
And they can treat too.
and you can treat. Surgery, we don't do radiation during pregnancy, but we can certainly safely give chemo and safely do surgery, especially when you're out of that first trimester.
Yes, so please, 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 if you notice something, say something, because the last thing you want is your husband to have to take care of a child without you because you didn't do anything about it. And so say something so then they can take care of it.
And these husbands, they don't like to go to the doctor themselves, but they are really good. You would be surprised how many husbands, spouses, partners have found masses in my patients. Yes. Yes.
Well, I guess that's the same as the women that find the testicular cancer.
So if that man or that partner say they feel something, take it seriously, please. I've had a lot of partners find cancers.
Wow. Who knew? I had no idea. But yeah, so it's very important, and we will keep harboring that because I'm telling you, the first person that should recognize it is you, and then you tell the doctor, because by the time you go to the doctor, it could have been, months and months after the fact, and it could have grown and grown and grown, whereas you could have found it when it was very small and easily taken care of. I think there was like 2 people, if not 3, in the last year that I personally knew that were diagnosed with breast cancer. So, and they're all here. Thank you today. So please just make sure that you take care of yourselves. That's all. And thank you again for your time. And we'll call you again, of course.
I'll be here whenever y'all call me. I love it.
Thank you so much. Have a great day.